thank you very much to our panel. We'll now open it up to the audience. We don't have a roving mic, so I'd ask you please to speak a little bit louder than you might otherwise be inclined to. If you could introduce yourself, and if I could make a plea, if you use an acronym, please tell us at least the first time what it means. Gentleman in the second row and the lady on the far left.
Thank you, Chair. Can you hear me okay?
Yep, absolutely.
I'd like to start with a comment.
Sorry, could you introduce yourself?
Sorry. Woody Kahn, editor of the Journal of Public Mental Health. Let's start with a comment and then a broader question that relates to almost all the speakers. Mike said something about his deprived valley in South Wales. If we get hung up on resources, we won't learn the lesson from Janusz Korczak, who actually wrote that line about giving children a voice, listening to the voice of children. He was the orphanage doctor in the Warsaw Ghetto. You can't have fewer resources than that. But having read his work, Angela might be interested to know that it's very much around assets and strengths and involving the children. And that's an example, I think, that could get to all of us in this time of austerity. You don't start with the money. Now, when I was young and idealistic 40 years ago, I was working with children in school with special needs. And if there's one thing we've known for 40 years, it's that the children, even with mild disabilities, say language disorders, are greatly at increased risk of adult mental illness. Mike mentioned child protection. And my favorite example came from the first Children's Commissioner from Scotland. They'd actually looked for depression and looked after kids. Sounds sensible, never been done before. 80% of the looked after kids in Scotland were depressed. That's about 8 times what you'd expect in other samples of adolescent children. And I think it was, who talked about drugs and alcohol? Might have been you, Paul? Can't remember, sorry. But Sue, who's one, knows that I work for Hamid. Oh, right.
So could I ask you, sir, to come to your question, please?
It's joining together the bits. The best thing we did for troubled families was improving literacy in at least one parent. Keeping kids out of care, which is what my Old Children's Trust aimed to do, and succeeded, and keeping them out of the youth offending teams. But none of this fits the current system of commissioning. So I'm so glad, Ian, perhaps this is primarily a question for you. How can we ensure that public health sees child protection is a major public health issue for children? That youth offending is a major public health issue for children. 35 out of 35 of the first yacht clients that I saw were mentally ill. 35 out of 35. How can we bring these different groups together, because it's not happening in the clinical commissioning groups?
One of our best friends is our local probation service, for instance. And so again, we got over the bit, well, when probation rings you up and says, can we send you some clients? You go, how are we going to cope with all those? To actually suddenly, you've got knowledge and a resource. And we believe, one of the things about being a GP, is that we're often rightly slagged off and saying, well, we can't get people, you're not registering mental health patients. So an example is, 2 of our highest cost patients who were going to casualty all the time were basically people coming out of prison, young men, angry men, coming out of prison, going straight onto booze and drugs, then trying to register with a surgery, couldn't register with surgery because we found excuses not to. We didn't like a man with a skull and making a lot of noise in the waiting room. And so they couldn't get social services because they weren't registered with a doctor. And so they went back to prison. And it went round and round until our esteemed team grabbed them, made sure, got them up out of bed early before they got their drinking and the drugs, took them down to a doctor's, got them registered, dealt with their housing problem, dealt with their benefits, and dealt with the families. Those 2 are off the map. They've saved over £100,000 each per year because where were they using their health casualty, A&E? Where else did they have to go? And I didn't realise, but the probation guy said to us, he said, I've got to thank all you guys because Sandwell is the highest decrease in violent crime in the country. Why? Because who produces the violent crime? Okay, it's angry young men who, I'm afraid, are tending violent to their partners. You deal with both. But who deals with angry young men in the mental health sector? I don't want to see them, they might hit me. Right? Well, if you bring in rules of probation, get some anger management courses and so on, bring it all together, it works, and how much have we saved? Does that answer your question? Yeah.
Right, we have Mike and then Paul waiting to come in on this one.
I just wanted to pick up on one word that Woody used, and that was deprived. He called the valley I worked in deprived rather than poor, and I'm really glad you did, because of course poverty, material poverty, is a huge problem. 1/3 of the children in Wales live in material poverty, but there is a danger of equating ill-being with poverty, material poverty, and well-being with material wealth. And that, of course, that equation doesn't hold. It's possible to be living in poverty on a sink estate in Wales and to have well-being, and it's possible to be in a middle-class professional, well-off family and to have no well-being. And some of the most sterile families that I worked with, and some of the kids at most risk of their development, who are in middle-class professional families. So poverty, of course, is important, but let's not create an equation that doesn't work.
Yeah, just very quickly, I wanted to draw attention to one of the case studies in the report, the one that talks about community-led commissioning. It's a great example of actually not the professionals leading the process, but actually skilling up a community to be able to lead the commissioning for itself. And it's absolutely at the heart of the sort of asset-based, strength-based approach that we'd like to see adopted more widely.
Okay. Sandra on the left, then the lady in the middle, and then the gentleman right.
I'm Sandra Law, trustee of Weekend Mental Illness. There are some frustrations in the structural issues in this field, because not with Rethink, but with another organisation, I was trying to do some innovative work on employment and mental health. So there's a huge minefield of voluntary sector organisations trading on each other's toes, falling over each other, all trying to do the same bit of innovative work with the same people who are the only ones who wanted to do it. You need at least a mapping exercise. I'm not quite sure who would be in charge of this, and I hesitate to say the government because that's not quite the right, doesn't feel right. But somebody somewhere needs to, Kingston someone needs to do a proper mapping exercise of all these organisations trying to bring together, particularly in employment, which I think is the current issue really, trying to get people into recovery, into employment, and try and coordinate some of this and free up some of the frustrations, because you spend all your time and going after the thin funding streams that are, here and there and then pulled, it's just a bit like that.
Stephen,
yeah, I mean, I think that's absolutely right. I think I was involved in the project that RAND Europe did for both the DWP and Department of Health, and I think that was in part an attempt to do that, to take a sort of step back and look at, where's the evidence, what could work, what tweaks could we make to existing services. So that's come up with, one of the things that we're working with the Centre for Mental Health on, is looking at how you can build in the principles of IPS, individual placement and support, into IAP services. And I think, I'm really pleased to see mention of that in the report. I think there are big challenges, for example, with the work programme. We've been working with some supported employment charities who don't get a look in the work programme. The specialist supported employment people are too small to have to put loads of money down to be part of the work programme. So the payment by results mechanism, the black box thing, really excludes people with that specialist knowledge. But I agree, it is a very busy area. This is something where you end up potentially having counterproductive, initiatives where people aren't cited. There's not enough collaboration, and there's not enough incentive built into the system to make sure that evidence-based interventions are the ones that get the resources, and the people who know best how they work are involved in implementing them. So I do agree with you.
Jenny Edwards from the Mental Health Foundation. I'd really like to welcome the report. I think there's a lot of very important things in it. I hope all the parties will back major parts of the whole agenda that you set out. For me, what's interesting is the sense that we're on the verge of a tipping point, that there's excellent examples like Ian's practice and in other parts of the country where people with a drive and the right sense of values can make it work. But what's needed is to tip that over so that the sort of early majority of services actually feel it can work for them as well. And that, I think, needs initiatives at both levels, and I'd be interested in your thoughts and comments on that. I think at local level, it's not clear who has the public duty to ensure that happens in an area. So I'd be interested in your thoughts on who, if all of us as taxpayers and citizens were to look to somebody in an area to say, this isn't happening here, and it's your responsibility to make it happen, who should we look to? And the other challenge always in system change to make it hit the mainstream and start to take off is that the Treasury's model is to divide up the money we all give to government into what turns into many, many, many tiny streams with different objectives. And then people go through agonising steps to try and put them back together around a problem that's not just one small thing, that needs a holistic approach. And where that's worked in areas, it seems to have involved just enough money and some coordinating approach so that people will come together and bring their budgets with them. And I think of programmes like Supporting People and so on that could make that happen. So what do we do to get the Treasury to accept that has to happen, and whose responsibility is it in each local area? And then we can change the system.
Angela, are you brave enough to...
Well, I don't think I fancy addressing what makes the Treasury change. But, it might be interesting. I think Jenny's point is really powerful because a lot of us, I think, spend our time looking for where that lever might be. Who is it? Where is it? What is it? And I think one of the things that we try to do in this report, which is not novel, but it does try to pull together what a lot of people in this room know, and a lot of organisations know, that somehow you've got to harness the power of what Ian describes, which is the real power of people, the voices of children, all those things. But one of the pleas that I would make is where parts of the system, like health and wellbeing boards in some areas, like the absence of mental health in some public health plans, where we see difficulties, we don't tiptoe around them. We actually say, come on, this is your responsibility as well, and we use some of the power that Ian describes to make some of those changes. And I think, in a way, Jenny, like you, I would probably look for people with passion in a local area and try and point them at some of the places where change should happen. So I think it's a combination of individuals and passion and knowledge, and something about saying there are parts of the system not working terribly well, but given that they have those responsibilities, we better try and make them work well. So I think there's something about pressure as well locally. With the Treasury, I wouldn't dare to try and answer that, and I'm not being flippant, but the argument about where the payoff comes of saving money, for those of us who've worked for years around criminal justice, know that the very hard argument has been, how do you get the payoff early on for what you might spend later on? But I think, again, there are some indications of hope. Have a look at what's happened with diversion schemes. Have a look what's happened with changes in police stations about the provision of services. Victor's here, he's had to use a very powerful voice sometimes to talk about some of what happens to the people at the very hard end of mental health problems when they come in contact with criminal justice. Again, you do start to see some changes. So I think some of this, as you suggest, is about a gathering of the forces and looking to see whether there is some kind of tipping point.
Mike and then Paul.
I agree with everything you both said, but I just wanted to pick up on what you said about how you get change in a locality. I think the problem at the moment is there are wonderful examples of innovatory practice, but at the moment it seems to depend on the inspiration and common thinking of people who are simultaneously at the heads of services in that local area. When I worked in Blaenau Gwent, for example, we had no money, but we had common thinking about how we would service our locality. When we all left, it collapsed. And the problem is how we can get it from inside inspirational leaders' heads, many of whom are in this audience, I guess, and actually into formal policy and practice. Then we'll be at the tipping point. And the other thing I wanted to say is, actually, heaven forbid that I should hold a brief for any government department. But my experience at the moment actually is the Treasury is the best one to deal with, because I think they get the idea of social capital and spending to save. I hope. Cross your finger.
Anything to add on the Treasury?
That means 2 or 3 very quick sort of reflections, really. The first is that it's not an either or, sort of bottom up or top down, and therefore some of the things we've said in the report about the role that NICE plays and how that can be quite instrumental in terms of driving change, at least in a healthcare context. Secondly, there does need to be accountability of directors of public health at a local level. That needs to be more transparent. That's why tools like Atlas as a variation, which we've now published as part of this work, are very critical ways for which we can drive some of that. And I think the other thing is, interestingly, the Treasury gets subjective wellbeing. The Treasury actually uses it in the way it does its own analysis as part of cost-benefit analysis. It's NICE that doesn't get subjective wellbeing when it comes to the way in which it then makes decisions about what is cost-effective and what value we attach to things. And as a consequence of that, it devalues therapeutic mental health related interventions relative to pharmacological interventions, and it also says these must be done, these, well, you can do them if you want. So that is a really important shift which I think we need to see alongside some of the community based commissioning that I was talking about earlier on.
I'm delighted to say that Geraldine Strathdy, who's the new advisor from NHS England to the government, is very pro this sort of thing, and in fact wrote forward. And she's actually got money from Health Education England, I think, to educate or to train every GP commissioner lead from the CCGs in the country, which we're going to be part of. Education, I mean, and training and development, it's got to go all the way through this, and I think there is a challenge to Health Education England, to the universities and lots of people, to actually release the money so that we can divert it that way. But hopefully that's going to start the role, and GP commissioners, who are meant to be the people commissioning a lot of these services, will get the idea and will lead the way.
Right, 2 gentlemen from the front row trying to get my attention.
Yeah, Kevin Jones, member of Parliament for North Durham. Can I thank you, Ian, for your presentation, because I think putting the patient in the driving seat is one of the important points. The problem I have with it, though, locally is, and I like the idea of a clearinghouse with allowing people to choose different pathways in terms of the community sector. But the problem in my area is it's the way the contracts are actually drawn up. So I've got some very good local mind groups and others do some fantastic work, but they're unable to actually bid for the contracts because it's the way the contracts are actually configured. Likewise, Stephen, in terms of the DWP, I have a fantastic women's project in my constituency that's working with women with long-term mental health problems and the people from probation service. Last year it cost them £800 per person to get them into work. Talk to the DWP, which I have local, try and get them a contract. They can't, because of the way the contracts are actually constructed, there's no way that organisation, which is quite a small but very effective organisation, could actually bid for that contract. So I'd be interested to know how you've actually approached that process of commissioning local groups.
We've got away with it so far, but I don't think we're going to get away with it much longer, is the answer. And it's a huge problem. And what people don't understand is the difference between commissioning and procurement. Yeah. And commissioning, so I worked with a commissioner who trained the librarians in the library wellbeing. You know, she looked at, we mapped out the services and said, where do you fit in here, and how do we write the contracts to fit that? Not, well, who's best to do this one over here? How do you get integrated services with procurement? I really don't know. And watch this space, I don't know what's going to happen to our services next year or two, because we keep getting told they need to go out for tender. The other huge problem is we've got contracts with loads of people, and there's single tender actions. And so we're being beaten up and saying you shouldn't have single tender actions, that's against European law. You've got to procure them. We haven't got the staff to procure them anyway. And so I really don't know what's going to happen. I must compliment you. Are you from Sunderland?
Durham.
Durham, okay, because I mean, Sunderland's the other place, I suppose, actually, which is having huge reductions in mental health beds because they act, and it's meant to go because they actually allowed their community mental health team to actually sort things out, and they don't turn people away. They sort out the problems, and they found it's easier actually not to say to people, you don't fit our services. It's how can we help you? Let's respond straight away, and then we'll put you into services.
But there's not a lack of willing amongst the community and voluntary sector. It's just the fact the contracts. There's no way they could actually bid for.
I think, I mean, it's a huge political. I mean, I'm going to have to throw one back to you. How can you help us in the
I'll try.
get that through to the politicians?
Well, I'm just in response really. I'm not a politician, and I've got to go in a minute. But it just strikes me. It just strikes me, which probably makes me more a politician. But anyway, the thing that strikes me about what you're saying, Ian, the comment was made earlier, is that first of all, the immediate response, my advice to small voluntary organisations struggling with contracting, is actually to engage with bigger ones. I mean, practically, that can work. Secondly, I think you're absolutely right about commissioning. I'm actually quite concerned to hear what you're saying about your services and the conditions that you're in. Certainly, I'd be interested from the point of view of your relationship with your CCGs, because some of the things that you're saying about what appears to be telling you about the way in which you can do commissioning, to my mind, are actually wrong. I think there's far more flexibility available to do the kind of thing that you're doing than it might not be convenient, but it's certainly possible. And I'd be interested in following that up in a bit more detail.
Yeah.
What the system, the systems of procurement, commissioning, contracting, NHS England, health and wellbeing boards, in a nutshell, they should all help you do what you're doing. And if they're not, then the question should be asked, what are they contributing? It's very simple. It's not rocket science in the sense that the key driver, and I think that the report points to this, is that the key driver of well-being and mental good health is actually not the patient, but the patient citizen. It's the people who, and they should be at the heart of designing the service, because it's just like anything else. People do not use services they don't understand. And services they don't understand are a waste of my money and yours. So commissioning is at the heart of this, and there's too few examples where commissioning happens, and too many examples of where poor procurement and very bad contracting occurs. I can understand it, in fact I sympathise with some of the professionals forced into a position of having to buy what they did last year but only cheaper, but it's not good enough.
I'd even say it goes on that in most areas, the easiest thing to do is just give your money to the secondary care trust because they are the experts in mental health.
That's just not
That's what's happening.
No, I'm very interested in understanding how that works.
Gentleman in the front row.
So, that's fine, I'm used to following, but Paul Farmer, Chief Executive of Mind, and one of the commissioners, along with other people in the room. Just a couple of points I really wanted to pull out from the discussion. I mean, first of all, this is a question of leadership, and the starting point for this, I think, is the political leadership. And as far as I'm concerned, this report should be a kind of essential reading for manifesto writers of all political parties, because I think it sets out something very fresh and new about the way in which we should be thinking about mental health. Not least because this report actually only starts talking about mental health services on page 37 of its report. And I think for far too long we've spent too much time starting with mental health services and not thinking about these wider factors that are really discussed very broadly here today. The second point, I think, is this really key message about the voice of people with lived experience. I think the Commission has done a good job trying to really reflect that. But I think it's only just scratching the surface of the growing power of people with lived experience in terms of people wanting to engage and change their local communities. And I think we can take real inspiration from what we've heard from Ian and others about how, if you embed the voice, not just the voice, but the lived experience of people with their own experiences of services, of the workplace, of their local communities and of their families, that we can design services that will really support people. And then my third point is about people who are most marginalised and most vulnerable. And I think the report I think really flags up the importance of making sure that we talk to and reflect those experiences, people from particular BME communities, as Angela has mentioned. So I guess my question is, how do we embed the leadership for this, not just at a political will level, but also at the level of other key leaders? And if you were to put this report in front of 3 people, who would you put it in front of tomorrow?
Okay, could we very specifically get answers on that from each of our panel here? Which 3 people would you either physically put the report in front of, or make sure that they knew where to find it on our website?
My initial thought of that is I could put the report in front of lots of people, but how do you get them to read it? Okay, and you know, I've had that problem with reports about our services, you know, and so on. So yes, you know, of course we want, you know, want to read the report and probably the Prime Minister and so on to you know, about well-being really. So I suppose that's 2. Yeah.
Who would your 3 be, Jim?
I think, well, probably George Osborne probably ought to be on the list somewhere. I think Francis O'Grady from the TUC, because I think it's really important that we think about, you know, the voice of employees and people of working age who are going to have to work longer and be iller as they do so. So I think there's some big challenges there. And then I think I probably would try and find out, you know, from someone in one of those big anonymous investment banks somewhere, where, you know, people are still being told stress is for wimps, sickness absence is for wimps. If you've got a problem, just pull yourself together. One of those big, often American but not exclusively so, investment banks.
Okay, so I should add that our CentreForum staff are taking notes here. So this will be implemented on our joint behalf. Your 3.
I'd put the report in front of the 3 senior civil servants in Welsh Government who have just taken away the core funding from an organisation of which I am the chair, so that instead of being able to relax and think strategically around community needs, we now have to go chasing every single little pot of money, even though it's beyond our mission statement, and we'll exhaust ourselves in the process. I think core funding in the 3rd sector is absolutely vital. It then allows us to make really innovative and strategic moves around leadership instead of being drowned in the morass of contracts and so on.
Okay, I'm sure if you give Holly the email addresses, we'll make sure those 3
well, if you
get
give me a heavy enough one, I'll beat them over everything.
Excellent.
Well, I'm going to be very cowardly and say I can't think of 3 individuals, but I think of 3 groups. Through George Osborne and his investment in the North and in the Midlands, I would be saying, if you want to be a successful investment region and city, so council leaders, not the good old social services folk, you have to think about the mental health of not just the workforce, but the potential workforce and the families and the children. So I'd be putting it under the noses of local government, but not the usual suspects, I think, in local government. I'd be putting it under the nose of, probably, because I'm like this, the most hated media figures I could imagine, to point out to them how they don't face up to what happens when you demonise people with mental health problems and people you suspect might have mental health problems. But perhaps more positively, I'd be looking for the Radio 4 in the morning to run this story and not some other health story. I'm going to be partial enough to say that, and I really think we've got to use it to do some of that work. So I've got a lot of people, but only 2 groups there. Is that all right, Chair?
That's fine. Paul?
Wow. Yeah, that last one, absolutely. Then we would say that, wouldn't we? I think there are 3. I would put it in front of the person who reads and tells the Prime Minister what are the things they really should read.
Yeah.
Because Prime Ministers don't read all the reports, but they read the ones that the people they trust tell them should be read. And I hope this could be one of those. Not the person, but the role. I think actually the most important pivotal role within the Treasury for driving these sorts of changes, because they are very much an enforcer across government, is the role of the Chief Secretary of the Treasury. I say it's not the person, it's the role. Whoever has it has that ability to be within government departments and effectively holding a government department to account. So I think getting them to read and see that the mission of the Treasury is not just GDP but well-being is very important. And then I think because he, I think, is a man on a mission and we need him to see this as part of his mission, Simon Stevens of NHS England needs to read this and see this as being part of and complementary to the mission he's already on.
All the tweeters could do it by tweeting it. And then it goes under lots of other people's
Okay,
noses.
I think we've got quite a long list there. We'll do our best to implement that. Two, I think, both happen to be men, sort of on the aisle and then on behind you, sir. That's you.
Simon Lawton-Smith, now retired, though many people I used to work in the mental health policy sector.
Can you speak a little louder?
Sorry, Simon Lawton-Smith, retired, so I can say what I want instead of what I usually have to say. What I would like to say, the one group that wasn't mentioned there at all, I think, were the people who educate and train the workforce, both in the NHS and social care and public health. And I think the Mental Health Foundation, who I used to work for, last year produced 2 reports which I think are very relevant to this debate. One on interagency working, one on the future of mental health services, and almost every single message in this report today is fantastic in sort of cementing what was said in those reports last year. Get the people who are educating and training the next generation of health workers, social care workers, public health workers, managers in the NHS. Get those people today to start thinking about this holistic way of providing mental health care, preventing mental health problems develop, and you have sorted it. If you don't start that education today, I suspect you're going to be doing what we've been doing for the last 10 or 15 or 20 years, which is come up with very, very good reports that say absolutely the right thing. But on the ground, it's only a few intensely passionate people like Ian, passionate politicians like Paul, who will actually be doing what we should be doing throughout the country.
Okay. Gentleman behind you there.
Thank you. Andy Bell from Centre for Mental Health. It is an absolutely brilliant report, so well done to everyone involved. Thank you. And I wasn't, so there we go. I think really the importance of political leadership is really difficult to underestimate here. And a message of hope is that with other mental health charities and the Royal College of Psychiatrists, we've now been encouraging local authorities to identify member champions, people who are elected to the council, to support and encourage mental health locally. We've now got 30 councils signed up to that, including Sutton and Durham, with thanks to Paul and Kevin for encouraging that. So it feels like there is a groundswell of political leadership locally. And I think in a sense our efforts to depoliticise health policy have perhaps not always been helpful. And maybe thinking about 3 key audiences, so I'm stealing other people's opportunity to say 3. Something about mainstream health and how money moves around in the health service really needs to be looked at, whoever's in charge of government next. Clearly school policy and clearly the work programme, and that's about taking mental health from its little box that we live in and taking it out into those big places where the big decisions are made and having some kind of voice around those. And I guess my question would be, how can we collectively put that message across to those people who we find hard to reach?
Anyone want to come in on that specifically?
Always a nice, easy question. Thank you, Andy. And I think part of the answer was the many sets of 3 that you've just heard, plus your 3. And also, just reflecting back, we're very lucky to have had Sue involved in our work, given the new role she's going to be having around education. And it occurs to me that one of the things that we might do as part of our next 12 months, because as I said, the Commission is not just for publishing a report, it's actually about how we take this agenda forward over the next few months, is to see whether or not we can get in a room the key influencers and decision makers around education. I think that point was absolutely spot on. So I think that in a way might be the way to move this agenda on, by actually winning the hearts and minds of the educators and those who write the curriculum.
Can I add one thing?
Please.
We've heard quite a lot, absolutely rightly, about putting the voice of people who have experience up front and centre. That's sometimes a bit of a cop-out for letting a lot of lone voices wander off in the wilderness. People have been doing that. We've had a great user movement since the 1970s and so on. The responsibility, I think, of people in this room is to help support, to foreground some of those voices and to make sure that we're able to get people into those positions where they can make their own case. And I think sometimes one of the things we're looking for is real experience, people coming forward, being prepared to talk. That is incredibly powerful. And I think in this room, we can put some of that together. We might help make some of those political messages much stronger.
Can I just, please, can I just say something about education? Because I think we've got to be very careful when we say we're just going to talk to the educationalists. My experience is when we were doing our education courses for GPs, and actually we do cross-training across the sector as well now, is that we used to go along and they certainly the top universities, or the Russell Group, as they like to say, oh yes, we can do a mental health course, we just take a bit of CBT here and a bit of this there. And it wasn't until we got to some of the newer universities that they said, you teach it how you like as long as you get the learning outcomes. And that was when we could bring patients in and you know, and actually patient experiences and that kind of thing. And it's a real challenge to educationists to actually, you know, it's another paradigm shift. They've got to come down from, we know how to teach mental health, to actually, well, actually, what do we need to teach? And right from the beginning.
Mike, you make a point?
I want to build on what Angela just said about people's voice and people being experts in their own experience and relating that to children and families. I think there's a feeling that some very vulnerable sections of children and families are so hard to reach that they never get seen. In fact, my experience is they get seen by masses of people, but they never get heard. And one of the reasons why they never get heard is because it's nobody's responsibility to sit close to them through the whole trajectory of their childhood and adolescence and early adulthood. We now have a system of multiple services. However well they're coordinated at the top, they hand people on from one to the other instead of somebody sitting close to them throughout that trajectory. Scotland have thought about this, and in their most recent Children's Act, they have actually postulated the idea of a named person for every child whose job it is to follow them throughout their career of vulnerability and to offer them advocacy and help at every stage that they need it. They've no idea who that person should be, you know, but it's a very interesting concept and we might follow it here. And the second reason I think why children often are not heard is that some of them are so dispirited, so downtrodden, so deprived that they're not used to having their voices heard. And even when you give them space, they're too weak to make their voice heard. And they need advocacy, proper advocacy, to express their feelings on their behalf until they're strong enough to do it for themselves.
Stephen, you're waiting for me.
Yeah, I think it would be good if we had embraced the philosophy underpinning things like appreciative inquiry. Because it seems to me, when we do studies on this sort of thing, sometimes we approach them by saying, you know, let's try and pull together the evidence, and then as a result of that, try and come up with ideas for new initiatives that would pull it all together and make it work. And in this field, in the field of mental health, what we find the whole time is there are loads and loads of initiatives where we know that they work. There's a strong evidence base, where there's some practical experience of how to make them work. And one of the frustrations that we have is that despite all that evidence, we just fail at the ability to scale them up. And sometimes it's a political issue. Sometimes, you know, new ministers come in, and because they didn't invent it, then of course the existing good practice can't have any merit, and they have to do something shiny and new. But I just don't think we're very good at learning, and we're not very good at scaling up existing good practice across the whole system. And so, rather than seeking, you know, shiny new initiatives the whole time, I really do think that we need to be better at appreciating what's worked and trying to work out ways for making sure those work at a system level.
Thank you. We've just got time for just one more question.
Mine was back to the point of who we educate and who we can send these messages out. Sorry, Lorraine Khan from the Centre for Mental Health. How we can get these messages out about virally to certain key stakeholders. Education's already been highlighted. For me, there are two others really who we need to make sure that we focus on, one of whom is the Police Crime Commissioner in local areas and their potential role in investing in early intervention, in parenting support, and there are some areas where they're already doing that because they've recognised that investing in these interventions can save them money and the workforce money later on. And the other organisation, which is much more difficult, it seems to me, so my question would be, who would you target, is housing. Because housing providers also in some areas provide parenting interventions because they recognise that through their inductions they can identify families who might need support, they can do that critical engagement, and it benefits the stabilisation of the tenancy as well as the local community. So I'm wondering who you would target to make this go viral for that workforce, for those key stakeholders, who would we be targeting?
Okay, I think if in answering that question specifically, I could ask each of our panellists the one thought that they would like to leave us with as we get to our closing hour of 12 o'clock.
I mean, the one service we did tender out and successfully, we actually involved 2 housing agencies, and that's our health and wellbeing service. And so they get it actually, and a lot of the housing associations do get it. And I think that really does lead to the, which links with the resilience stuff. You know, what makes people tick and what makes people resilient? And it is all the, you know, the obvious things really, the security, the community, the downtime, all the Maslow's stuff. And this is the message we've got to get out actually. If we want a healthy society, that's what we have to do. And you know, goodness gracious, you know, the Prime Minister's tried, but then they get swung away all the time towards, well, how much does this cost and the financial thing. And that's what we've got to change in my CCG actually, because it's run by the accountants, not by the people who are looking at the well-being of the population. And that may be a challenge for other CCGs too.
Yeah, I mean, I think it's hard to pinpoint one person or role. I think there's clearly a public health responsibility here. So you know, as that all sort of comes out of the mix, I think local public health officials are the people who need to focus on this more. I suppose the one thing I would just pick out from all this, which resonates with other work we've done looking at other health conditions, you know, in the context of employment, but not just employment, but social inclusion more widely, is that if you want to try and marshal all the arguments, the economic arguments, the social arguments, the employment arguments, and so on, early intervention is where it's at. And it's getting the whole system to orient itself to be better at early intervention. Don't wait for the car crash to happen. We're really good at dealing with car crashes. You know, NHS is a treatment service. Let's focus much more on prevention and early intervention, because that's where we're going to get both, you know, cost-effective interventions, but also clinically and socially effective intervention.
Stephen's just shot my fox, so I'll suggest something else. The 3 things that I've picked up from today, and they're 3 Ps really, and they're all about stayability or stickability, and I'm glad that you said, Paul, that this is not the end, it's the beginning of something. And the 3 things I'd want to stay with are, first of all, staying with the problems. These problems are not short-lived, the solutions aren't short-lived. We need to stick with them. The second thing is we need to stay with people and their voice and what they say they require of services and mould our services around them. And thirdly, we need to stay passionate. Because if we don't have any passion for this, then we don't get anywhere.
Thank you.
I agree with what other panellists have said, and I think my one place that I would be wanting to strengthen massively is primary care, both in its commissioning role and in its provision role, because I think it's got the most opportunity for being effective locally with public health and with others. And I think that's where that integration story goes. With housing, Lorraine, isn't it difficult because so many of the housing organisations get this? Financially, they find it very hard to raise the money now to be able to operate in those ways. So I think we're back in that territory of where locally and nationally we could start looking for results and putting at the front of the conversation where things are working well and see whether we can work back to that. because there's a fine tradition of housing organisations in the past being very active in this area, and I think financially they're in a difficult place at the moment. But I think you've made a very good point.
Yeah, all of those points, absolutely, and just want to sort of underscore a couple of points, if I may. The Care Act that was passed just quite recently does a couple of things which are very relevant to this. One is it is the first Act of Parliament that enshrines the idea of wellbeing. It doesn't just have a fluffy word and leave it undefined, it says what it's about, and that I think is going to be transformational in social care, but not just social care. It has to begin to then also infect the way the NHS works, and it also speaks to the housing piece. And that Act, the whole of its journey through Parliament was about the housing sector banging on the door and saying, why are we not here? We should be part of this conversation. There is a huge appetite, I find, amongst housing providers, particularly social housing providers, to be really part of the solution to delivering well-being, to delivering a more sort of holistic and rounded form of care. And one of the things that Sue Bailey and I saw when we went to Lille as part of our inquiry, we went and visited a number of projects. We looked at some really excellent work around children's mental health, but we also visited some really interesting collaborations between mental health community providers and their housing partners, and how they saw housing as part of delivering their mental health offer more effectively, and how actually the offer to be able to have an influence over the housing provision was the service that the mental health provider provided to the housing provider. So it was really seeing the sort of collaborative value of all of that. I mean, I absolutely agree with the point Stephen was making, and that's why, as Paul Farmer was saying, the first chunk of this report is all about wellbeing. The first part of this report is all about creating a new concept of a national wellness programme, something that Public Health England is sort of beginning to grapple with itself now. We need to see them lead that, and why actually it's not about creating often new services to promote wellbeing and wellness. It's about doing what Ian was talking about earlier on. It's about getting the map out and finding where they are, and then making it easier for people to actually find them when they need them. So that social prescribing piece and so on is really key to all of this. So for me, as I said several times now, it's been really good to launch this today. Really great to have so many useful pieces of feedback. But this is just the start. It really is to actually make this a reality.
Thank you. But before asking you to join me in thanking our panellists, just renewed thanks to the commissioners who were not on the panel. And I'd like to ask the two specific CentreForum staff who were most involved to stand up and take a bow. Holly Taggart and Mark Lethbridge.